The broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to the HDSA Caregivers Corner webinar series. Today we're pleased to welcome Dr. Martha Nance, who's going to talk about diagnosing juvenile onset HD. Before I invite Dr. Nance to begin, I'm going to go over how to ask a question as well as how to access this webinar after broadcast. Questions will be answered after the presentation. However, you can send a question at any time. To send a question, go to the control panel that appears on the right-hand side of your screen. You'll see a panel for typing in your question. After you type in the question, hit the send button. This webinar will be available for viewing approximately 1 week after this broadcast on our national website, www.hdsa.org. To access this presentation, go to the HDSA website and scroll down to the homepage to the frequently used shortcuts section on the right-hand side. You'll see a link to the Caregivers Corner webinar series, as well as copies of the PowerPoint presentation. You can find all of our webinars archived in a Living with HD section. Now I'm really thrilled to introduce Dr. Martha Nance. Dr. Nance is the Medical Director of the HDSA Center of Excellence at Hennepin County Medical Center, as well as an expert on juvenile onset HD. Dr. Nance is the author of HDSA's Juvenile HD Handbook, as well as the reviewer of the HDSA Family Guide series publication on juvenile onset HD. She also wrote the JHD and the School Experience resource. Now I'm so pleased to welcome Dr. Nance.
Great. Well, and it's my pleasure to be here and to talk about juvenile onset Huntington's disease. Hopefully there will be plenty of time during the presentation or after the presentation for people to ask questions. First, I just want to mention my disclosures. I do get research grant support from a number of companies for research on Huntington's disease. And my husband also is involved with some medical research. Let's just talk about juvenile Huntington's disease. I'm going to start with kind of how do you define the disease and how is it different from adult onset Huntington's disease. Talk a little bit about how we usually go about diagnosing the disease, and that will lead into a discussion of the situations where it can be very difficult to diagnose the disease. I have a couple references at the end, and in between I'll tell you about the exciting thing that happened last week, or maybe it's 2 weeks ago now, to make it easier for people with juvenile Huntington's disease to get disability payments. So what is juvenile onset Huntington's disease? Well, the first question is, how do you define juvenile? I think many people define a child as being somebody under 18 and an adult as someone over 18. Some people define it, the breaking point, as age 20. Some people use age 21. And it may be also different in different countries depending on what the age of emancipation is in the different countries. So you'll see me flip around sometimes from one to another. I tend to use under 20 just because that divides your first 2 decades into 2 decades, and then it's sort of everything after that. But I don't think it's wrong for somebody to label a person at age 20 and 2 months as having juvenile HD. Juvenile HD represents about 5 or 10% of all Huntington's disease cases. And we know just from experience that about 90% of people with juvenile onset Huntington's have an affected father, meaning that the other 10% have an affected mother. The young onset age is at least explained in part by having larger CAG repeat numbers in the Huntington gene. I think probably most of you are aware of the gene mutation that causes Huntington's disease. Everybody with Huntington's disease has the same mutation at the same location in the same gene, and that type of mutation is called a CAG repeat expansion. It's just a segment of the gene that is repeated a number of times in a row. Any number up to about 35 is normal, and any number that's bigger than 35 can cause Huntington's disease. Now, often in children with juvenile onset Huntington's disease, that repeat number is 60 or above. You'll see in a later slide that I use the thought that people with juvenile HD may have numbers of 50 and above. There's not really an absolute number of CAG repeats that specifically determines that a person is going to have onset as a child or not have onset as a child, but the repeat numbers tend to be on the bigger side. Now, how do you get a great big repeat number? And it turns out that a parent who has a CAG repeat number in the range that can cause Huntington's disease, say, for instance, 42 repeats, if you pass that gene on to your child is quite likely not to have 42 repeats. The repeat number tends to get bigger, but it can get smaller. And when the gene is passed on by a male, there's more of a tendency for the repeat number to get bigger, and how much bigger it gets tends to be greater. So we see bigger increases in the CAG repeat number when the gene is passed on by a male. So a man with 42 repeats could have a child with 60 repeats, but a woman with 42 repeats is somewhat less likely to have a child with that big of a repeat number. And so we sort of can explain the idea that more kids have affected fathers by these changes in the CAG repeat number. So what are the clinical features of juvenile onset Huntington's disease? And I've just made a table here that shows some of the differences. So the onset age, obviously, is sort of how you define the disease, with juvenile onset being under 20 and adult onset being age 20 and over. Both juvenile and adult onset Huntington's have a movement disorder, but the details are a little bit different. So an adult with Huntington's disease tends to have chorea, those wiggly, fidgety, involuntary movements, and often has some degree of incoordination. But in children, particularly the younger the child is, the more likely they are not to have chorea, but rather to have stiffness or rigidity. Another doctor word for stiffness, especially if it's accompanied by sort of a twisting or a cramping, sometimes doctors use the word dystonia. So rigidity or dystonia are somewhat more likely in a child than chorea. And again, in a young child, it may be more of a change in speech or some drooling or difficulty swallowing. Those may be some of the initial motor symptoms, where those tend to be later symptoms in an adult. Both kids and adults with Huntington's disease will have changes in thinking and memory, or what doctors refer to as a cognitive disorder. In the case of adults, that can sometimes be hard to recognize. If somebody kind of lives a quiet lifestyle and does a job that isn't intellectually challenging, they may be able to hang on to the skills, the cognitive skills, or the tasks that they do that use their thinking and memory for a long time. Kids, unfortunately, well, they'll say it's unfortunate, get tested all the time. So kids are being tested in school, and they have SAT exams, and they have IQ tests and things like that. And so one of the first things that people may be aware of in a child with Huntington's disease is a change in their school performance. Somebody who used to be an A student is now getting B's or C's or failing to keep up. So in some ways, it may actually be easier to recognize the change in cognitive function in a child than it is in an adult. The third area that we see trouble in people with Huntington's disease has to do with the psychological or psychiatric or behavioral symptoms. And the details are very variable both in adults and in children. There are some adults and children with Huntington's who have essentially no behavior problems or no mood disturbance. But quite often, those would be the most disabling symptoms, or the symptoms that need the most treatment. There's, I think, been a greater awareness that kids, particularly adolescents, who are developing the onset of Huntington's disease may have very severe behavioral problems. And we'll talk in a minute about this is one of the kind of sticky areas where doctors struggle to make a diagnosis of Huntington's disease in the setting of purely psychiatric or behavioral symptoms, even though families and schools kind of figure it out long before the doctors do, that there's got to be something going on. But we struggle with that a little bit as physicians. And other features of the disease, I think in adult onset Huntington's in particular, we quite frequently see weight loss. Sometimes the weight loss is due to people forgetting to eat, or not having the money to buy food, or not preparing foods appropriately. Kids tend not to have that problem as much because they have mothers and fathers who look after their meals. So weight loss may actually tend to be a little bit less of an issue in kids, at least in the first 2/3 of the disease. But one of the things that we see in kids that's pretty uncommon in adults is seizures. So epileptic seizures are said to occur in 20 to 25% of people with juvenile onset Huntington's disease. And they may be pretty mild, or they may be more difficult to manage. A lot of people think that the course of Huntington's disease is a little bit quicker in children than it is in adults. I think it still is measured in years to maybe a couple of decades. Maybe it's slightly on the shorter side, but I'm not sure we really have good data proving that one way or another. So those are some of the features that are a little bit different from juvenile HD compared to adult onset HD. So how does a doctor diagnose juvenile HD? Well, just as we think about in adults, we're looking for a change. So this is a degenerative disease process. So whatever skills or abilities a person used to have, what we expect to see in somebody with Huntington's disease is that those skills decline. They have declining academic performance. They have declining athletic skills. They're more clumsy. Or in a very young child, you might, where the developmental changes are so rapid, then children should be gaining developmental milestones. So should be learning to walk, or learning to ride a bike, or learning to throw a ball, or learning to read. A very young child with the onset of Huntington's disease may fail to achieve normal developmental milestones. So that's the first thing that the doctor has to do, is to listen to the story, and listen particularly for a history of some kind of decline. And the first slide kind of talked about the motor and cognitive aspects of decline. Then there's also possibly going to be a history of behavioral or psychological or psychiatric symptoms, which, as I suggested before, is typically all over the map in terms of the severity or the nature of the symptoms. Depression is common. We all are aware that the suicide risk is said to be higher in people with Huntington's disease than in the general population. Particularly in adolescence, there can be very severe behavior issues. I use the term antisocial behavior. I think the psychiatrists in the room would probably yell at me for using that word somewhat loosely. But what we often see is behaviors that could be construed as antisocial, so burning down the church, or getting in fights, or sometimes inappropriate sexual behavior, sexual aggressiveness, substance abuse, so alcoholism in a 12 or 13-year-old. So typically the behaviors that make us really think about Huntington's disease would be fairly severe behaviors, not somebody who just is crabby when they come home from school and and mouths off at mom and dad, which is something that all teenagers do, or at least mine did. We struggle a little bit with the large number of people in the world who have who nowadays are diagnosed with attention deficit disorder. This is a very common diagnosis in the general population of kids, and so we have to be a little bit careful thinking that a child has Huntington's disease just because they've been told or diagnosed with, they have or diagnosed with attention deficit or hyperactivity disorder. That's such a common condition in all kids nowadays. Another thing we look for, obviously, in diagnosing Huntington's disease, it's very helpful if you have a family history of Huntington's disease, particularly if you have an affected father. Is it possible to have no family history of Huntington's disease and still end up with juvenile HD? Well, yeah. There are 2 or 3 situations where that can occur. Rarely, I think I have 1 or 2 patients that I'm aware of where the child started to have symptoms before the father did. And there still, in those families, was a family history, but the last known affected person was the grandparent, and then the child developed symptoms before the parent did. Another situation would be if there's what doctors call non-paternity, which is that the biological father isn't the same person as the social father, and the biological father actually had Huntington's disease or has Huntington's disease. And then the third situation would be adoption, so where you either don't know what the family history is, or perhaps is misdiagnosed in the adoptive parent as something else. So those are situations where you could end up with juvenile HD having never had a family history or no apparent family history. So then what do doctors do? Well, they put on their little white coat and they go in the exam room and they start examining the child. And the exam has 2 or 3 major parts to it. Aside from just the general exam, we focus particularly on the motor features of Huntington's disease. If you look carefully, you can often see abnormal eye movements. So people with Huntington's disease may have somewhat slow eye movements, so as they're trying to follow an object passing through the field of vision, the eye movements don't quite keep up. It may be hard for people with Huntington's disease to initiate eye movements, so we often have a test where we have them look from the right to the left and back to the right and back to the left quickly, and they may have difficulty initiating those quick jumping eye movements without either blinking or turning the head, or the movements may be slow. We listen to speech. We look for slurring of the words or dysarthria. We look for difficulty swallowing or excessive drooling. We look at the limbs. The strength is usually normal in people with Huntington's disease, but the muscle tone may be increased. So when you just go to kind of wiggle the arm around, the tone may be increased compared to normal kids. So there may be rigidity or spasticity. And then if we pull out the reflex hammer and start tapping on the arms and legs, we may see that the reflexes are quite brisk. And then we look at the gait and the balance. So some kids with Huntington's, because their legs are stiff, will be sort of up walking on their toes rather than as one should flat on the feet. In adults, we look at difficulty with what we call tandem gait, where you walk like you're on a tightrope, 1 foot right in front of the other. Now, a lot of kids can't do that at certain ages anyway, but if you are at age 13 or 14, you're old enough, you should be able to walk on a tightrope by that age. Or if you know that a child was able to do that a couple of years ago and now they're struggling to do it. Similarly, standing on 1 foot is something that a 5-year-old doesn't do very well, but a 10-year-old can do for at least a few seconds. And so again, if there's a change in performance on that task, that might suggest that there's a problem going on that's affecting motor function. I always say to my patients and families that I think the office examination of thinking and memory is very superficial, but we can still do some degree of assessing thinking and memory in the exam room. Compared to other children of a similar age, can the child talk about things that he's doing at school, and does he have appropriate knowledge of things that kids that age should know about? I think I may put it in a following slide, but I do think that what helps the most in assessing cognitive function in kids would be, and actually in adults also, is to do formal cognitive testing, or what people call neuropsychological or neuropsychometric testing. You just get a more detailed view of thinking and memory if you do formal testing than if you just do an office exam. So I did say that on my next slide. So the second bullet point refers to the neuropsychological testing. It's particularly helpful if you have done it before and you have something to compare to. Again, if a child has a progressive neurodegenerative disease, then you're likely to see a decline in their performance on tests if you do them, every 2 or 3 years. I often would do an MRI scan in a child suspected to have Huntington's disease, partly to make sure you're not missing something else, and partly to look for the changes that we sometimes see in children with this disease. When it starts very young, it may affect not only the caudate nucleus of the brain, which is a part deep in the brain that tends to be affected most in adults with Huntington's, but you may actually see diffuse changes in the brain. So there may be shrinkage of not just the caudate, but even the whole brain. And there have been a few case reports where Huntington's disease particularly seemed to affect the cerebellum, which is the back part of the brain, the coordination part of the brain. This is typically in the very young children. So those are some of the tests that might be helpful, both to sort of rule out other things and to support or confirm a diagnosis of Huntington's. And then the final thing, obviously, is doing a gene test that shows that you have the gene mutation that causes Huntington's disease. The gene test, of course, is kind of a problem, because if the gene test shows that you have 30, that's a repeat number that, boy, would be pretty darn unlikely to cause symptoms in a 10-year-old. So I tend to think of using the gene test in a child with juvenile Huntington's disease after I have already made a clinical diagnosis of juvenile HD, and I use the gene test simply to confirm what I already know, which is the child has HD, and sure enough, they have the gene mutation that causes HD. What doctors are very fearful of is evaluating a child who has attention deficit disorder, whose father has Huntington's disease, and doing a gene test and finding the child has 39 or 40 repeats when the child has no motor symptoms, no cognitive symptoms, but just the attention deficit problems that are so common anyway. And now you've basically done a predictive gene test on the 10-year-old. The attention deficit probably has nothing to do with the CAG repeat expansion, but now you know the child will someday develop symptoms of Huntington's disease. So what are the challenges? And I just alluded to one. So in a child who has attention deficit disorder, or who has some kind of developmental delay, possibly for unrelated reasons, should those children get tested for the Huntington's gene because they're from an HD family, in the absence of any other symptoms to suggest a declining performance either on motor or cognitive tests. Another challenge is if the family history is missing. I always tell people there's a difference between a negative family history and an absent family history. So being adopted and not knowing who your parent was is an absent family history, or I'm sorry, it's a absent family history, not a negative family history. But we still worry a little bit about diagnosing HD in somebody where, as far as we know, nobody else in the family has ever had it. Because we know from the published literature that the majority of children with juvenile onset Huntington's have an affected father, we're always a little bit less likely to think of HD if it is the mother who is the affected parent. That being said, a couple of the children reported in the literature who had absolutely the youngest onset ages, like age 2, actually had affected mothers. So it's not impossible for a child to have HD if it is the mother who's affected, but it's significantly less common. We also struggle with patients who have only psychiatric or behavioral symptoms. So, you know, we know that the teenage truancy rates and alcohol and drug abuse are common things in teenagers who don't have Huntington's disease. And so should we always assume that any child from a Huntington's family who is having behavioral problems or depression or substance abuse, should we assume that those children have Huntington's disease, or should we first think in terms of the stress that the child is under living in the family situation? There are what we call so-called soft signs. So as I said, a 5-year-old child isn't going to be able to stand on one foot for very long, but an adult ought to be able to stand on one foot for at least a few seconds. And if you ask an 8-year-old to hold their arms out in front of them and just hold them still, you'll find that they really have a hard time holding their hands still. The fingers tend to wiggle a little bit. Well, in an adult who you ask to hold your hands out and the fingers start to wiggle, that's one of those things that make you suspicious that the person might have Huntington's disease. But in an 8-year-old, that's normal. So we struggle a little bit with children who have these things that we might call soft signs, things that are normal in a 5-year-old or a 10-year-old, but are not normal in an adult. Does that, in the setting of a child from an HD family, does that mean that that child has Huntington's disease? Well, probably not. We struggle with CAG repeat numbers that are in the, that shouldn't say 30 to 45, it should say 35 to 45 range. So now I've used 3 different numbers. I said, well, kids might have a repeat number of 60 or above. Kids might have a repeat number of 50 or above. Every so often you see a kid who truly has juvenile onset Huntington's disease whose repeat number is in the 40s. But I'm always a little bit nervous blaming all that child's symptoms on HD if the lower the repeat number is and the younger the patient's apparent onset age is. So we may hesitate a little bit to make a diagnosis of HD when the repeat number is that low. You might want to think twice about the diagnosis. And I had one patient, my child who had onset at age 2, who had a very large repeat, CAG repeat expansion of 250 repeats. And the test that is ordinarily done in the laboratory can't really pick up on a repeat number that's that big. And so that child actually had a false negative gene test result. That shouldn't be a issue in most children, but could come up in a child with a very young onset age or very severe symptoms and a very large repeat number. So those are some of the challenges that doctors run into when they're trying to diagnose juvenile HD, and some of the situations where a doctor may be a little bit reluctant to rush into that diagnosis. So I know at HDSA they often get the phone calls from the frustrated parents. My doctor didn't diagnose HD. It took them 10 years to agree that my child actually had HD, and I knew that the child was affected years before the doctors would actually admit it. There's also the risk of over-attributing symptoms to Huntington's disease. So I think sometimes when you live in an HD family, it certainly happens in adults, and I'm sure it happens in parents of children. I've always said the most difficult thing when you live in an HD family is when you get together at Thanksgiving and somebody says, pass the gravy, and your hand wobbles a little bit as you pass the gravy. Well, in my family, you just say, well, that person's a klutz, but in an HD family, everybody's looking at you, and they're all thinking, oh, maybe this is the guy in the family who's going to get Huntington's disease. So there is a tendency to look very hard and to potentially over-attribute symptoms to Huntington's disease. So is there some kind of middle ground that we can find between, every time the child ever trips once, saying, oh my God, he's got Huntington's disease, but also not waiting 10 years after there's clearly a problem before the doctor feels comfortable with the diagnosis. And to me, I think the middle ground that makes sense, and this is what I tend to do in my clinic, if there's a parent who's worried about their child, I would absolutely have the child come into clinic. I would do a neurologic exam. I would do whatever general lab work seems to make sense given whatever other health problems they have, if any. I would typically, in a child, do a brain MRI scan. A CAT scan doesn't show enough detail, but an MRI scan gives more detail. I would do a formal cognitive assessment or a neuropsychological assessment. I would recognize that many kids from HD families are living in a stressful situation. Either there's a parent in the home who has Huntington's disease, or worse than that, the parent isn't in the home and is either gone or in a nursing home. These are often families under substantial stress. So if the child is depressed or anxious or irritable or acting up or acting out, to have a formal psychological or psychiatric evaluation, and to treat the depression, treat the anxiety, treat the irritability. Do whatever you can within the family or the school to optimize the situation. Sometimes you can get a school counselor involved. Sometimes we get county social workers involved. Sometimes moving the affected parent out of the house can make a lot of can really benefit other people living in the house. So whatever it is that seems like it would optimize the family and school situation, and then see where you are in another 6 to 12 months. Perhaps at that point repeat the neuropsychological assessment. Remember, this is a degenerative disease process, so if you wait a year, a normal healthy child will have gained skills or might actually remember the tests that you did the last year and therefore do a little bit better on them, whereas a child with Huntington's disease is likely to have declining skills on formal cognitive testing. They may have declining motor skills if you repeat the neurologic exam. So I think that there's a reasonable middle ground that acknowledges that parents can pick up on things that doctors can't quite see. We do the best that we can with the tools that we have to collect baseline information at the point that there is concern, and then look again in another year or so. And if it seems like there's a neurologic disease causing a decline in function, then maybe you would consider doing the gene test at that time. So I want to just shift and talk a little bit. So the talk was supposed to be about the difficulties in diagnosing HD, but I want to talk just a little bit. You roll the ball uphill trying to get a diagnosis, and then you continue to roll the ball uphill trying to get good management of the symptoms. So what things are involved in managing juvenile onset Huntington's disease? And I think a lot of times parents end up having to be the general contractor to find all these services. There aren't very many places where you can find all these people in one clinic all at one time. So the neurologist or or the pediatric neurologist would sort of be the team leader. This is a neurologic disease, so typically it would be managed by a neurologist. And that person would take care of if there are medications to use for the movement disorder or the seizures, and then they would tend to be the ones that would initiate referrals to other people on the healthcare team. You might need a psychiatrist to help with the psychiatric or behavioral symptoms. A psychologist can help with the managing behavioral symptoms and can help the family to handle the child's condition as well as possible. The neuropsychologist does the cognitive assessment. The speech therapist can look at the drooling, the swallowing troubles, the speech changes in speech, communication problems. The physical therapist can help work on gait and balance and may be able to help the physical education department at the school on developing an appropriate phys ed program for the child. The occupational therapist looks at things like safety and what equipment might be helpful, does sort of functional assessments of the child's ability to do things like get dressed and bathed and toileted, and are there issues in the school. Sometimes kids, as they go through a course with Huntington's disease, may need a personal care attendant in the school to help with things like bathroom hygiene. A dietitian can certainly help the family on healthy eating, and as things move on and the person has difficulty with certain textures of foods, you can alter the texture to make the swallowing safer. If there's a problem with weight loss, we can work on high-calorie foods. The social worker can be very helpful in helping in legal, financial, logistical issues, identifying community resources. Some people need placement outside the home. So these are some of the health professionals that you may need to have as part of your team. And if you're in a small town, you may have to work with your local physician to try to gather together a team like this. Other people on the team, obviously the pediatrician needs to be involved. This is not a disease that finishes its course in a year or two. You have a child who's going to be living for 10, 15, maybe 20 years with this disease, and so general age-appropriate care is important. You need to get your immunizations, and you need to have discussions as you go through puberty about appropriate management, sex education, things like that. Good health of the teeth is particularly important in people with Huntington's disease. The disease affects your ability to chew and swallow, and if you combine that with poor oral hygiene and you start losing teeth, it only makes matters worse. So good dental care is important. You need to be able to work with the teacher and the school on an independent education program if things are changing to the point that the child is not able to be in a regular class full time. And then the lay organization, the support groups and so on can be very helpful for patients and family. I think a lot of times people with juvenile HD, everybody with juvenile HD feels like they're the only one in their community, because they may well be. But now we live in the computer era where you can find each other online. I think a lot of folks have sort of online support groups that can be very helpful as well. So the exciting thing that I wanted to mention just briefly, on April 11th, the Social Security Administration announced that they what they call a compassionate allowance for SSI and SSDI for children with juvenile HD. This goes into effect in August 2012, and it should make it much easier for children with juvenile HD to get the financial support that they need without jumping through a million hoops. So I personally thank the people who made this possible, which was folks at the Huntington's Disease Society of America. In particular, she's going to minimize it, but I think Jane Cogan was very involved with this. Sam Frank is a physician up in Boston who was very involved in this process. And you know, it's a small breakthrough, but we'll take small breakthroughs. So if you have questions about that, I'm not the right person to ask, but you can certainly contact folks at HDSA, and you can also go to Social Security and remind them about this new allowance. So I'm actually going to stop there. Oh, well, I guess I have a couple references. There's this really wonderful book that was written 5 years ago now called the Juvenile HD Handbook, published by HDSA, and I think still available. I tried to write the book in a way that it would be useful not only for doctors and nurses, but also for families. So most of the stuff in the book should be things that regular people can understand, or at least understand parts of. I always encourage people with juvenile HD to get a copy of the handbook and show it to their doctor, so that the doctor knows there's something to kind of fall back on. And then I include a couple other references that for those who are like to have actual references from the medical literature. These are two sort of review articles about juvenile HD. So I'm actually going to stop there and take questions.
Great. Well, thank you, Dr. Nance. And just to everybody as a reminder, to ask a question, you type it into your question pane and you hit send. And just a little bit of a clarification. You can absolutely contact us at HDSA to learn more about the compassion allowance. Although SSA did announce it on April 11th, it won't be in effect until this August. So this August is when the compassion allowance becomes effective.
Okay. So I have one question that says, is there something written for teenagers that describes the symptoms that might be expected? My son, who's 13 years old, like everybody else, assumes that all behavior or physical problems are related to Huntington's disease. There are a couple efforts to provide information to teenagers in language that they can understand. One is a project called Stanford Hopes. Jane may have to correct me if I get this wrong, if you know the actual name. But,
you've got it right, Stanford Hopes.
Stanford Hopes, yeah. And I think you can just Google Stanford Hopes and up it will come. But they've really made an effort to write materials that are written for kids about HD. The other marvelous online organization that came to be earlier this year is called HD Yo. So this is the HD Youth Organization, which if you just, again, just type in HDYO into Google and it'll pop up. HDYO, their thing is that they are by the kids for the kids. So it's sort of grown-up kids that are doing the writing, but their intent is to provide information to kids living in HD families ranging in age from 5 to 25. So those would be two resources you could kind of look for. And the cool thing about HDO, they also have a chat room so that people can connect with each other, and it's been a wonderful resource. So I have a second question. In terms of social behavior, relationships, and communication, other than understanding one group are children and the other adults, how does caring for JHD patients versus caring for adult HD patients differ? And if it does, could you explain or give some examples about how? So I think part of it is that the social situations that kids and adults find themselves in are different. So adults are kind of by definition emancipated. They're accustomed to doing their own thing, for better or for worse. And so as the disease progresses, adults, I think, feel the restricting nature of the disease, and some people don't want anybody helping them, and it's really difficult for them to accept help. I think that's a challenge for a significant subset of adults. kids come from a world where they've always been assisted in one way or another. They haven't had to cook for themselves or drive or manage their finances, and they're used to having other people do things for them. They too, I think, as they go through the course, find that more people have to do more things for them, but I think they're actually, in general, almost a little bit more accepting of support and help and assistance than an adult might be. Relationships, and again, relationships that, you know, it's sort of the difference between a child taking care of a parent and a parent taking care of a child in terms of the relationship differences between kids and with JHD and kids and adult children caring for adults with HD. So I'm not sure if that answered the question adequately, but there are some respects in which caring for children with HD may be a little bit easier. The other thing is that you have the whole school system that exists, and the mandate for the school system is that they have to deal with all kids, and there is no such thing for adults. So you know, we have to go to great lengths to find things like daycare for adults, but there are systems that already exist to help kids. So here's another question. If a child passes away before the diagnosis and the biological father shows signs but won't test, can the biological sibling be tested? And I assume we're talking about the sibling of the child that died. And the answer is yes, the child can be tested. Under what circumstances you would test that sibling depends on whether the sibling is having symptoms or not. So if you do a gene test before you have symptoms, you would call that a predictive or pre-symptomatic gene test. In the U.S., I think the vast majority of us think that we should not be inflicting predictive gene tests on children, but that the children should wait until they are of an age to legally make decisions for themselves about whether they want to have that pre-symptomatic gene test or not. But if this person's 10-year-old sibling died before there was an HD diagnosis, and the father is at risk but doesn't have symptoms, and you're 20 years old and you want to have a predictive gene test, you could go to a predictive testing center and talk to them about the situation. And we have done predictive gene tests in people whose parents didn't want to be gene tested. Another question, what studies exist today that JHD people could get involved in? And if people want to know how can they help JHD efforts, what can they do? So there are a couple studies going on currently looking at imaging and sort of fancy brain imaging and fancy computer cognitive tests in children. A couple of these studies are actually going on at the University of Iowa. So you could contact the University of Iowa Center of Excellence to find out more about those studies. I believe there may be similar studies also at Johns Hopkins, although I'm not sure what age they're actually looking at. Some studies are looking at kids who actually have Huntington's disease. A lot of studies are starting to at least think about looking at children who are at risk for developing HD but not yet having symptoms. We're actually going to try and convene a meeting of researchers who are interested, researchers in the U.S. who are interested in juvenile HD, and actually clinicians interested in juvenile HD. We're planning to have a meeting in June to try to get a little bit more organized around both efforts in caring for people with juvenile HD and also around research in juvenile HD. So I think to stay in contact with Huntington's Disease Society, to stay in contact with the the various research groups, the Huntington Study Group, the HD Buzz, things like that. You'll hear about things as they come up. Another question is, how much do we know about hormones in children with JHD and how they can affect symptoms? That would be a wonderful question to ask of other parents of kids with HD who are probably the ones who know more about how hormones affect JHD than anyone else. As I suggested earlier, we sometimes see sort of dramatic behaviors in adolescent kids who are developing HD, and I've kind of always thought that that's due to the combination of hormones kicking in at the same time that HD is kicking in. And you know, it's hard enough to know what to do with your testosterone or your estrogen at age 13 when you don't have HD, and when the Huntington's disease affects your ability to kind of keep the lid on your emotions and to keep the lid on your behaviors. And boy, when those hormones start to kick in and you've lost the ability to rein in your moods and your emotions, then sometimes it really comes out in the form of explosive behavior. And I think it's both boys with hormones and girls with hormones. You'll see these issues. As far as sexual activity in kids with HD, I think that there's a risk in both directions. I think there are some, typically males, but could be females also, with HD who are sexually aggressive, who are either promiscuous or who are sexually aggressive towards other people. But there's also the concern that there are people with juvenile HD who are sexually vulnerable, who don't know how to protect themselves or can't recognize signals that they're getting into a bad situation. So you know, having conversations about sex and really for young girls, making sure they are protecting themselves from pregnancy, and for both people making sure that they're protecting themselves against sexually transmitted diseases. These are going to be really important things for a parent to do, and if it's hard, it's hard enough as a parent to deal with this stuff, you know, to have the doctor or the school nurse or somebody help out with those discussions, and also to make sure the child is not in situations that are going to be dangerous to the child. So, and nobody else asked any questions, and there's still 27 people on the line. So the other 22 of you need to ask something.
That's right. There are about 6 minutes left, so anyone with last-minute questions, please ask them.
Okay, I got one here, which is, are there any prudent actions, diets, or recommendations? This is actually a great question. Any prudent actions, diets, or recommendations that parents can incorporate that would potentially delay onset in children at risk? The sort of party line answer to that in the HD research community, unfortunately, is that we haven't found anything that has any proven ability to delay or stop or reverse or prevent the disease. I think sometimes many of us struggle with just eating healthy. That would be a good place to start, is just eating healthy. So children need protein, children need vitamins. There was actually a thing that just came out last week. It wasn't about Huntington's disease, it was about Parkinson's disease, that, believe it or not, suggested that the old apple a day might actually protect against Parkinson's disease. Well, holy smokes, if there's any chance that that might help at all, we should all be munching apples. The same study showed some benefits, and actually the apples only helped men. It didn't show up to protect as a protective effect for women in Parkinson's disease. It only showed up for men. The same study showed some minor effects from berries like strawberries or blueberries, and actually did not show any protective benefits from red wine or green tea, which are a couple of the other compounds which are things people drink that contain some similar compounds. you probably don't want your child drinking red wine anyway, but boy, eating berries and apples and fruits and vegetables and things can be important. Physical activity is really critical. If you're going to have a disease that is going to take away your ability to control your movements, then you better darn well go into that disease in as good a physical shape as you can. So those would be a couple things, and there are other things that I'm sure people can come up with on their own, but I would just stick to kind of common sense things. Eat right, sleep right, have people around that care about you, feel good about what you do, succeed at the things that you do, stop to smell the roses periodically. So sometimes the families that kids dealing with HD live in are very stressed, and people need the opportunity to live a normal, happy life, and that, as much as anything, will help. I have another question, which is my daughter, who passed away at age 19, spent years with serious itching, which ended up with her not being able to wear clothing. She also tore at her skin. Have you seen this much? And I would say I heard that same issue just once recently, and I don't know if it was, I assume it was a different person that was being discussed. So now I've heard about it twice. We don't usually think of Huntington's disease as causing any change in sensation or what we call neuropathy, but we do certainly see people who have obsessive compulsive behaviors, and whether the obsessions are around bowel movements or food or a sensation of something on the skin. I would wonder whether it was sort of a sensation that wasn't really real, but it felt real. Could it have been a dietary thing? So sometimes people aren't eating well, and if you get deficient in certain vitamins, you may have itching as a secondary phenomenon. So not sure quite what to say about that. I've heard about that now in 2 patients, and I'm sure you went to the skin doctor and tried creams and potions and so on, and they didn't really help. There are drugs that we sometimes use to simmer down funny sensations in people who have nerve troubles, and one could certainly try those too. And in 1 minute, I have one more question. If a child with JHD is over 18, what would you suggest that would help with the tricky process of helping to manage finances and case management without transgressing the child's rights? And that is a difficult thing to do. How do you gracefully go from being a kid to being an adult with HD and make sure that you have safety nets in place, but that you're allowing the child to be as independent as possible? I don't have a good single strategy to suggest, but I think if you have a good relationship with your child, and a lot of kids move out of the house into group homes or foster homes or sort of assisted living type of situations, and that gives them the independence, but yet maybe you manage or co-manage the finances. It's going to have to be sort of addressed on a case-to-case basis, I think, depending on where the kid is with the disease and what your financial and emotional resources are. So my clock says it's 1 o'clock.
Dr. Nance, we actually got a few more questions. If you want, do you have a few more minutes? Or
I do. Sure.
Okay, great.
Oh, holy smokes, you're firing them up at me. Can you touch on how to handle schools and how JHD kids could be seen as manipulative when it really is HD symptomatology? That's sort of why I wrote my book, was to try to help with the schools. I think educate, and the burden ends up falling on mom and dad to be the ones doing the educating because there's sort of nobody else around. In my area, I'm happy to talk to anybody at the school who will listen. Perhaps you could get your child's doctor to talk to the school. HDSA has written a book, or has put out a book called JHD and the School Experience. So that book might be helpful to educate the people at the school. You just got to educate, and if you find one person who sort of gets it, this is also true for nursing homes and group homes and everything else. If you find one person at the school who seems to get it, who seems to understand your kid, or who seems to understand Huntington's disease, then you can sort of use that person as your ally or advocate or resource. So yeah, it is a tough one, but if you do it right, or you have the right people at the school, it can be enormously helpful. Another question, is stress a factor in bringing on symptoms faster, and if so, is there a general course of action that can help to reduce stress? And I was sort of touching on that a moment ago. Stress absolutely is a factor in many diseases, both neurological and otherwise. And as I said, I think many HD families are living with a high degree of stress all the time. You know, there are many different approaches to handling stress, everything from meditation and yoga and listening to your favorite music, and sort of individual ways to whatever it is that works that just makes your pulse level, you know, and your respiratory rate decrease. So there may be things that work for you on an individual level that may not work for the next guy. I think for me as a physician directing an HD team, I actually think that if we do our job right and people understand their disease and they're getting decent care, and they are knowledgeable about what's likely to happen next, that it takes a lot of the stress away. I think people have fear of the unknown. They have fear of what's going to happen next. And if you talk about it frankly and you know what's going to happen next, then even if it happens, it's not quite so bizarre or frightening or scary or unusual. So being well educated, feeling like you have support, not for yourself as an individual, for your family as a family, for your extended family as an extended family, and then you can use your creativity to do really neat things. I have more amazing people out here in Minnesota who have done marvelous things while living in an HD family. We have 3 different families who have started up group homes for people with Huntington's disease. So they're not only dealing with their own disease, but they're taking in other people who have Huntington's disease. And I always tell the story of my young buddy who's now grown up, that he started up our hoopathon in Minnesota when he was 10 years old. And 15 years later, they've raised $750,000 shooting free throws one at a time to raise money for research in HD. And you know, does that reduce stress? Well, you know what? I think it does. I think if you're actually doing something to make a difference, then your stress level is less. I have another girl who was in, I met this weekend, who's in college, who was taking her science class, and somehow the teacher started talking about Huntington's disease and made the silly question, you know, anybody here know anything about Huntington's disease? And she said, yeah, my mother has it. And then the teacher asked her to give a talk about Huntington's disease, and she did such a good job, he's asking her to come back this year and next year and the next year to talk to the biology class about Huntington's disease. So if you confront the thing in a creative but supported way, I think that can help to reduce stress. So, other questions?
Nope, Dr. Nance, I think that is it for now. So thank you very much for staying on and finishing answering the questions, and for everything that you do.
All right. Well, thank you guys for coming. It was a fun hour. Bye-bye.